Yeah.
All right, so this next case is a planning angiogram and mapping for Sersphere's radioembolization. This patient came to see us in clinic with a known history of cirrhosis and HCC. It's a 74-year-old male with NASH cirrhosis and a 2-centimeter segment 3 HCC with no other sequelae of portal hypertension, including abdominal pain, ascites, encephalopathy, or bleeding. Has a history of AFib, coronary artery disease, diabetes, hypertension, and gallstones. No significant medications. Next slide, please. So on, nothing particularly abnormal on exam or vital signs. And then lab-wise, pretty unremarkable, a MELD score of 11, Child-Pugh A, ECOG score of 0, and a BCLC A. Next slide, please. So as you can see right there in the circle is a segment 3, 2-centimeter HCC, arterial enhancing. Next slide. So the plan today is to do a transradial MAA mapping prior to Y90 radioembolization with Surtex microspheres.
So what we ended up doing was we used a sauce to go down. It's an exchange length Benson. Just used a reverse curve catheter to get down the arch. So we were actually able to drive the Ultima catheter into the proper hepatic artery. And so as you can see here, we just sort of puffed it in. Didn't really have to use a wire. We did an angiogram here. This catheter also has side holes, so you get good runs. We held it out here. We definitely see a GDA. The right gastric, there may be a little right gastric at the corner of the origin of the left hepatic, but we'll figure that out as we go. We were able to quickly basically cannulate the the gastroduodenal artery. And this is just a puff to show that we're in. And so we're going to coil embolize this. We're going to use a pod coil, which is from Penumbra. We used a lantern microcatheter, which is 2.5 French, sort of the in-between size between a high flow and a traditional high flow and low flow catheter. This coil is sized 1-to-1 to the vessel, so we chose a 4-millimeter pod. It's one of those things. I thought it was a 5, so I went one lower and made it a 4. I tend to overestimate the size of the coils or the arteries. So if you want to go ahead and start pushing it in, it's just find the edge. It's right there. Yep. So just small bites. Yeah. So we're going to ultimately do a segmentectomy with Surtex. Okay. It's going. Yeah. Here, straighten this out. Okay. Go ahead.
No, it's good.
Yeah. And keep going. Surtex has a pilot program for doing, basically it's double dose Surtex. So it's the same number of spheres, but twice the dose. The spheres are twice as hot. So here comes the coil. As all of our long microcatheters have, they have 2 markers, which is the 3-centimeter setback. So this one is a short, stiff coil, followed by, let's see, we're going to get to the transition here in a second. Yep, there it is. A really soft coil for a total length of about 30 centimeters of actual coil here. And we're going to see if we can just pack this in nicely. See, it's sort of soft. It's sort of taking the space there. That's the end of that. So that actually laid out pretty nicely there. You can use they have a little handle here. You don't have to use the handle, but they asked us to use it, so we'll use it. So I don't know if you guys can see this. It's a little handle, pull back. You hear a click. You actually get a visual feedback. It's hard to tell, but there's these 2 black dashes. There was 1 black line, now there's 2 dashes, so it's disconnected. And we're going to pull back, and we are good. So it's a little bit more space filling. It takes a little time for it to occlude, unlike some of the other ones. So you do give it, if you're a little bit patient, which is usually where people get burned, is they're impatient with the coils. So we're going to put 1 packing coil on top, which is just basically 15 centimeters of really soft coil, no shape to it. It has a little bit of a J, so it does bite kind of nicely. I puffed it, and let's see. There's 1 vessel. You can kind of see it at the very top of it. You can see 1 little vessel coming off, which is probably the right gastric off the GDA. So I want to make sure I cover that, and that's sort of why I'm adding another coil. We're pretty close. I agree. That's why I also chose a short one. So let's see. This is that 15 centimeter one. You can see it's packing in really nicely. It's pretty dense. You can see here. I don't know if you guys can see. There's 2. You can just basically pull the 2 pieces apart, and now it's detached. So you don't actually have to use the little plunger thing. There. So what we may end up doing is actually just trying to catheterize that vessel instead to get rid of it. We'll put 1 more coil here. So then after this, basically, you can go ahead and start firing it in straight. So yeah, after this, what we'll do is we'll probably go into the the left hepatic artery and do a spin. So, typically we do our segmentectomies with TheraSphere, with the glass, but we can do it with CerSpheres as well. We're doing it with CerSpheres for this one just because it's something new. We want to try it. He's not a transplant candidate, so we have a little bit of leeway with what we can do. Whoop, that one. And that's good. And a lot of times, sometimes what we'll see is we'll still see flow in the GDA. If I'm pretty sure we're dense enough, which I think we are, what I tend to do is move forward with the rest of the procedure and then come back and look. Yeah, so it's still flowing through, but if we just give it a little bit of time, that stuff will occlude on its own. So I'm not totally keen on adding more coils here. I think a lot of times if you're just a little bit patient or have something else to do, move on and go forward. So I'm going to see if I can just puff this catheter forward. Okay. So you can see, just a little bit of reshaping of the wire there. Able to get into the left without too much difficulty. And I'm going to just pull back just a little bit because I think we're pointing at the roof. All right. If we can go forward on the injector. Okay. And can we set up for a spin? So we put the right arm up. Left arm is down. All right. It's making it around.
So for the trainees in the audience, Rahul first checked his AP to make sure that the territory he's looking to cover is involved. Then he checked his lateral and adjusted his table height to make sure that our CT is appropriately going to cover in an anterior-posterior direction. And that's that shot of the lateral right there. You can see his GDA coil pack. You can see the left arm down at the side, and the spine is along the left-hand side of the screen. And now he's just checking the reverse direction of the II as it spins back to make sure that there's no collision and we're still appropriately covering.
Yep. We do a mixed arterial and portal venous phase. So we're going to do a run here. So we're going to do 1.5 cc's per second. And could you do a 12-second injection? Yeah, respire.
Respire
All right, so you can see the spin. I don't know if you guys saw it come around. Yep. So you can see the spin even without the breath hold. We got a pretty decent angio. I don't know if we're going to be able to use the embo guide with it, but you can see the spin, and there's the tumor. He's going to quickly try to set up the embo guide here. And so basically you just draw a tumor volume. You go to this planning thing. You can cut out all the bones and stuff. But I'm not sure what he's doing here. He's just going to set the catheter. And then you do auto detect, and there it'll show you how to get there. So basically, it's the segment 3. It's where we thought it was going to be. It's going to be that first branch off segment 3 coming back towards us. Back towards lateral. So we're going to basically get into that, catheterize that, make sure that's the tumor, inject our MIA, and then we'll be done.
Thank you, Rahul. I think we're going to go back to lectures.
All right, sounds good. See you guys later.